Welcome, everybody online and in person. Thank you for taking the time to be here and learn about some innovations in help for recovering with concussions. I get the honor of introducing our speakers tonight, but before that, there's food in the back, beverages. Feel free to just get up when you need to, stand, help yourself to more. We have restroom right out the hallway to the left, so it's very close by. And if you're welcome to stay afterwards for trying some of our bioelectric devices, we'd love to help you out and show you how they can help you at home or work or school, wherever you are. And a little bit will be no volunteers needed tonight. I will be introducing to you Dr. Reis, and then later we'll hear from Fran and Guy from the Bhakti Brain Health Clinic. Dr. Reis received his doctorate in chiropractic from Northwestern Health Sciences University, graduating with magna cum laude honors, and graduated from the University of Minnesota with his Bachelor of Science degree in kinesiology exercise science, with an emphasis in human motor performance in both athletic and therapeutic settings. Dr. Reis currently holds a diplomate in functional neurology from the American Chiropractic Neurology Board and is a certified brain injury specialist through the Brain Injury Association of America. He's completed thousands of hours of additional postgraduate coursework utilizing clinical applications and therapeutic interventions in the neurological and nutritional rehabilitation of traumatic brain injuries, concussions, and vestibular disorders through the Carrick Institute of Clinical Neuroscience. Dr. Reis is the founder of the Neural Connection in Edina, Minnesota, a specialized functional neurology and integrative rehab center focused on treating concussions, traumatic brain injuries, migraine, headaches, and vertigo. So please welcome Dr. Reis.
Thank you, first of all for being here. I know there are other things you could be doing on a Tuesday night. With regards to presentations and how I like to speak, we've got slides up here. I can talk all day on this stuff. I love what we're talking about tonight. But I think more importantly, what I want everyone to get out of this is I want this to kind of more so be a discussion. I mean, you came here for some reason or another, unless you were, forced to be here, which hopefully you weren't. There's probably something that you wanted to take away or learn. And so for me as a speaker, I'm always asking the question of what can I do to provide value for my audience? And so if we're talking about something or if I mention something and you're like, well, this is interesting, I have a question, shoot your hand up, right? I love fielding questions. I think that's sometimes the most entertaining part about a lecture. And there's a high chance that if you have a question, that there's someone else in the audience that has that same question too, right? So don't be bashful. I know it'll be scary to be the first person to ask, but that's always something that I want to make sure we're always aware and welcome. So I have a decent amount of slides tonight, and I don't plan to go through all of them. What I wanted to do is I wanted to give a bunch of material and content for you who's also here, but also at home as well, to make sure that you have a bunch of information, right? I often find that when we start talking about things like the brain, it's a bit intimidating, right? When we think about the brain, there's so many things that come to mind, so many emotions, so many thoughts. And so my goal is not to talk above you. My goal is to talk with you. And so if there are concepts or things that you don't understand, or if I breeze through something, raise your hand. Let's talk about it. But then more importantly too, you should all have access to my notes after today, if not already. So go through them, right? There's references, there's resources, there's a bunch of information in there. And I just want to make sure that there's a lot of value that's exchanged for you. Who in here is maybe a patient, somebody who has either dealt with concussions or around concussions? Okay, fair. And then who else do we have in here? Family member maybe? Okay, fair. Okay, cool. Some support as well. Fair, valid. Awesome. Okay, well, tonight we're going to talk about all things concussion. And a lot of these things and topics I talk about with my patients on a daily basis. So what I'm going to tell you is while there's a lot of things that we know about concussions, there's still so much that we don't. And hopefully tonight what I can explain a little bit more is the fact that a lot of these things are changing. Inherently, there's going to be something that I tell you tonight that will be wrong next year. And that's kind of interesting to think about, isn't it? So everything that we discussed tonight is relevant, is true to today, what I'm going to say. but there are going to be things that you can challenge me on as well too, and I'm open to that, okay? So when I start my lectures off, the first thing that I usually talk about, and I ask people, is what is your why? I love that book by Simon Sinek, and I think it's super important. And at the end of the day, this is my why. So there's my wife and there's my son Hendrix. He's 10 months old and he is teaching us oh so much. What is motivating for me is realizing, one, that those two are the reason why I get up every morning. I've had family members who have unfortunately struggled with neurological issues. So I lost my grandfather to Alzheimer's back in 2014. He also had prostate cancer as well too, which is near and dear to my heart. And seeing him go through that was really life-changing for me. I was in chiropractic school at the time. I was studying neurology. And my grandfather prided himself on teaching his grandkids how to do the Rubik's Cube. Everybody kind of know what the Rubik's Cube is? Yeah? Okay. So that was like our passage to kind of growing up a bit, right? And I'll never forget, my brother called me when I was in practice out in Oregon, and he was just bawling. I was like, Kyle, what's going on? Like, are you okay? And he goes, Grandpa forgot what the Rubik's Cube was. And that hit me super hard. Because when I was gone, I was seeing the big dramatic changes about what was happening with him, whereas the family members were seeing him on days, weeks, and months. And I'll never forget that moment, right? And so that really stuck home with me about the fact of how important this is. But we all think that we're a bit immune or we're not going to be affected by this until we are. And that's hard. And so that was a really big thing for me because I've played contact sports my entire life. I grew up in the Midwest. Hockey and soccer were like my gig. I never lost a header. I never took a hit that I wasn't ready for. And so for me, I was just a young kid playing sports and thinking that I was immutable, right? There was nothing that could happen. Well, lo and behold, later, days, weeks, months, years after that, things change, don't they? And so I've always wanted to have the best brain possible because I've seen not only way too many patients who've slipped through the cracks of traditional medical systems. That's not saying that they're wrong. It's just sometimes things maybe can't be treated like that. But more importantly as well, too, is like I've wanted to live a life of not having any limitations. So I'm a bit selfish, actually, because I don't want to have a life where I'm in my 40s, 50s, 60s, sometimes 70s, where I'm losing my memory, my thoughts. I want to be able to go, right? And I think most of us in this room probably do as well, too. So, this is something that I get asked a lot by my patients is, I got a concussion. Well, what do I do for treatment? And my first answer is, I don't know. So here I am being the expert on this topic and telling them I don't know. It's because it's the truth. Guy and Fran will talk to you all day about the patients that they see. They don't know either until they get data, until they do an exam, until they really look under the hood to see what's actually going on. Because concussions are unique. Every single person in this room could be involved in the exact same car accident with the exact same car, the exact same speed, the exact same vectors. And every single one of us could have different symptoms. We could have different outcomes. We could have different results. So there's no two traumatic brain injuries or concussions that are ever treated the same. And I think that's why we kind of do fail in treating these, is that for the most part, we want to find an algorithm or a formula to try and figure this patient out. But that's not how the brain works, right? So when you take a look at the brain, this beautiful organ that every single one of you possesses, right? This is the thing that allows you to listen to me ramble on, share my knowledge, and be able to process the information that we're actually talking about. Your brain is the master controller of everything. Now, what happens with a brain that goes and sustains a concussion is that it's kind of like pouring water on this laptop. We don't really fully know what's going to happen. And so that's why we have to go in. If I poured water on Guy's laptop, he'd throw it on some rice, and after a while, he'd go in and check and see, does the Microsoft Word work? Does the PowerPoint work? Does the internet work? Okay, maybe my Wi-Fi is a little glitchy now. We would get really specific in the programs that we would test and reassess and make sure that we revamp and update. And it's the same thing for a concussion, right? And when we think about the brain, we think about the brain looking like this, but it actually looks like this. Okay? It's full of networks. It's full of different patterns of neurons communicating and talking to each other. And this is where a lot of people get confused. They say, well, I got my head injury where I got hit on the left side of my head. That doesn't just mean we need to treat the left side of the brain. If it would be, our lives would be way easier, wouldn't they? Right? As a provider, if I could just have a patient come in and tell me exactly what they need to do to get treated, my life would be pretty easy. But those aren't the patients that we see. And so when you're looking at the brain, look at how beautiful this is formulated. Look at the structures that we're seeing. But more importantly, too, look at the susceptibility of the brain as well. There are parts of the brain that look like a suspension bridge. And what happens to suspension bridges when it gets windy or wind and weather picks up It starts to shift, it starts to change, it starts to turn and shear and twist on itself. And that's why when you have a concussion, that we don't really fully know what's going to happen or how it's going to manifest, right? So this type of imaging is a very high definition type of imaging that you're not going to find at your standard CT or MRI center. This is a specific type of MRI diffuse tractography that is only used in research right now, okay? But what's beautiful about this is it shows you the relationships between different areas of the brain and different parts of the brain. And I love using this because I think it's super important when we actually break down and talk about what a concussion is. Because when I was playing sports in the 90s and 2000s, when I would get a concussion playing hockey, my coach would ask me, hey, do you know what the score is? And I would look up at the scoreboard and I'd say, that's the score. And he'd say, great, you're ready for the next shift. And I'd be like, yes, I am, right? It's a very different conversation than what we're having today. We know a lot more about the brain. And unfortunately, what we know is that a concussion is it's a mild form of a traumatic brain injury. Well, when you flip that script and you tell a young athlete or you tell some weekend warrior who fell off their bike that, hey, you got a concussion, which is actually a mild form of traumatic brain injury, things change pretty quickly as far as their perspectives, right? So what we know about these mild traumatic brain injuries is that you don't actually just have to hit your head in order for this to happen. Some of my worst cases that are in my office right now are people that fell on ice, hit their tailbone, had those forces go up through the spine, affect their head, and all of a sudden now they're like, yeah, my hip hurts and my sacrum hurts, but I feel off. I feel dizzy now. Why am I getting brain fog? My sleep is now being affected by this. You don't have to actually hit your head in order to have a concussion. More importantly, you actually don't have to have any peripheral injury to the head to have a concussion either, right? So the patients that I see, a lot of them just have had trauma to the brain or to the body in some way, shape, or form. What's interesting about this is when you take a look at the numbers of people that actually sustain TBIs, and you're talking about a little less than 2 million people a year, right? Now that's the people that we know about, that we can actually classify, that we're aware of. These numbers are inherently probably low from a standpoint of situations like mine, where when I had a concussion, I didn't want to tell anybody, right? Because I wanted to go play sports. Or if I'm a professional athlete, I have money and I have a career on the line where I actually want to go play, and I'll worry about those injuries later, right? Now, if you're not playing sports, there's probably more of a chance you're going to probably admit that there's something else going on. What I think is so interesting about this, though, is that the third leading cause of traumatic brain injury is actually motor vehicle accidents. Motor vehicle accidents, car crashes. That's interesting, because I think for a lot of people, they think you only get concussions while playing sports. So while we think we know a lot about brain injuries, we actually don't. And why this is so interesting to me is that when you take a look at a lot of the classic signs and symptoms of a concussion, the headaches, the visual changes, the light and sound sensitivities, the dizziness, a lot of these things are categorically speaking generalized terms, all right? Now, people can have an array of these in different combinations. In a lot of situations, some patients don't have any light or sound sensitivity, but they have a ton of dizziness and nausea. Does that mean that they have a less concussion than someone else? No. Everyone's brains are different before the injury. Everyone's brains are going to be different after the injury. I think one of the common things that a lot of providers are unaware of and don't really field as well is the sleep issues that people have. 30 to 70% of patients who struggle with concussions and post-TBI struggle with sleep. What's unfortunate about that is sleep touches every single aspect of your health. It touches metabolic health. People who sleep poorly can have more sensitivity to blood sugar swings, and maybe be a bit leaner towards maybe being pre-diabetic. We know that sleep can help restore short-term memories into long-term memories. We know that sleep can filter out the day's trash. There's parts of your brain that are more active during sleep than they are during the day. These are the emotional centers. Sleep is fully restorative for your mental health, your physical health, and even your metabolic health. And so if we're not asking the questions, we're not going to get the answers. Now, where this gets interesting, though, is I can't tell you how often I get the patient to come in and say, listen, I was in a car accident. I got diagnosed with a brain injury, but I had an MRI and a CT and everything was completely normal. So they just told me to go home and rest. I was like, okay. Why do they still have symptoms? What we know is that the imaging that we use today is not sensitive enough to actually pick up those subtleties in concussions and brain injuries. Now, if you do have imaging changes that occur after an injury, that means that there's some real damage going on, right? Now, I'm not saying MRIs and CTs aren't helpful. They are, but they pick up things like brain bleeds, venous malformations, space-occupying lesions, tumors, things along those lines, and they're great for picking that up, but they're really poor at picking up subtle changes in the brain. Because MRIs and CTs look at structure, they don't look at function. right? So when you're doing an EEG with Guy and Fran, they're looking at function of the brain. It's the same thing that I'm looking at as well. It's much, the analogy is the same of like going to buy a car and only looking at the photo you see on the internet. Furthermore, only going to the lot and actually looking at the physical car you see, but you have no idea how the car drives, right? Function is me saying, get the keys, sit in the driver's seat, turn the car on, let's drive the vehicle, right? I want to see how the car actually operates. Do these inputs match the outputs? That's really where a lot of the research and data is showing us, is that it's great if you don't have any imaging findings. That's phenomenal, and you should get those diagnostics ran. But the moment that you're told, hey, you don't have any findings, all that tells me is that it's game on for rehab therapy and treatment. Does that make sense? Okay? Because here's what I'm going to tell you, is that we've classified concussions and mild traumatic brain injuries differently than we classify like whiplash. So same thing can happen for you whether you're in a car accident or whether you're playing a sport, right? This is kind of the same thing, and I want to allude on this a bit to make sure there's no confusion. Question over here.
You don't have to lose consciousness to have concussion.
Correct.
I had a neurologist fight me on that one.
There's so much data validating that. Yeah. And if you have any questions, I'm happy to send you some data on that too as well. Because you don't have to lose consciousness to have a concussion. You don't have to have changes on MRI or CT to be diagnosed with a concussion. You don't have to hit your head to have a concussion either. Yeah. So, question?
With we have CPT codes that says like loss of consciousness, a change in function, one being worse than the other.
Like prognosis for patients. Hannah's question is, if you do have a concussion and you lose consciousness, is there a difference in your ability to like improve or get like better with having like less than 30 minutes of loss of consciousness versus over? I would say the longer that you're out, the worse the prognosis would be. But I have yet to see that be something like staple, draw a line in the sand, and like 30 and below you're good and 30 and above you're like not in a good spot. I think it depends on the patient, because once again, I've had patients who've had loss of consciousness for longer than 30 minutes, but they were fit and they were healthy. They weren't diabetic. They didn't have heart issues. They were working out all the time. Like their brain could handle more of a stressor than somebody who was not in that situation and had the same accident. Does that make sense? So from a standpoint of like patients, and what I educate my patients on is, my goal is always to help them, one, always update their software. I think that's the easiest analogy that I can ever give a patient. Most people understand that now in 2026. But the bigger thing too is I want to give you the bandwidth and the energy and the battery capacity to go throughout your day and not feel like you hit rock bottom before the end of the day, right? And I think most TBI patients and concussion patients feel that way. They'll say, listen, mornings are my best time because I just got up from sleep and I have the most capacity to get things done. I'm wiped by 9:30 or 10 a.m. in the morning. Or my migraines kick in around noon 1 because I've tried to do work and I can't really function after that. That's not everybody, but I would say traditionally speaking, for the most part, people, they burn the candle at both ends pretty quickly. So whiplash is important, and it's interesting for me because, we spend a lot of time in the treatment of the neck, and whiplash is a really relevant thing. But what I'm going to tell you is I have patients in my office right now who didn't hit their heads, who have clean MRIs and CTs, who were involved in auto accidents, who present to me like post-concussion cases. And I've had to treat them that way as well. Yes, they have low back issues. Yes, they have neck issues. They have real whiplash issues. But what I'm going to tell you is when you look at the whiplash symptoms, are there any differences here that you see between concussions and whiplash? The only difference really that I put on there is TMJ, which you can still get with a concussion, right? These patients present the exact same way. To no surprise as well, when you look at the diagnostics and imaging with whiplash, once again, we see diagnosing whiplash via MRI or CT is very, very poor, which is even more relevant for those of you who maybe still have symptoms. A proper neurological examination, whether it's with EEG, bedside testing, looking at things that are more functional in nature, that's where the value lies. And I promise you, AI is not going to be able to replace that anytime soon. Okay, so take a big breath, right? So it's the same thing. And when we look at concussions and whiplash, right? So in this photo, we see people looking at the head and the brain and the brain moving back and forth. In a whiplash photo, we see the focus on the neck. But I promise you, in this photo, they're still looking and they're going to have damage probably to the neck in some capacity. In this photo, they're probably going to still have the brain moving back and forth, right? So they're really no different. And what we're finding is that centrally, when you look at what happens to the brain is just affected, okay? The central processor, the brain, is the part that actually becomes affected. Yes, you can have soft tissue issues and structural damage, But you have to understand that the brain is really what we're looking at for treatment and care and understanding. Because what happens is when you have trauma to the brain, you actually have twisting and shearing and rotating of that brain, like that original photo that I showed you where it's like the brain with the suspension bridge, right? It's a little bit more vulnerable to movements and rotations of the head. And this is kind of like making spaghetti and like twisting those spaghetti strands before you put them into the boiling water, right? Now I put this as like an al dente spaghetti because it's kind of cooked a little bit. Like you're not vulnerable or you're gonna like snap your neurons in half, but like you're more susceptible from a standpoint of having those forces go through the system. And on top of that, once you damage a neuron, you have inflammation, you have other changes that occur. Don't worry about any of these big terms. Just know that things don't go very well after that, okay? There's some really well-known mechanisms at play there. And why this is important is that not only do you see changes in the neurons, but you see the changes in the firing of how those neurons actually go out. It's kind of like getting a concussion is kind of like trying to plug your computer into an outlet that's a bit on the fritz. Okay, you don't actually know what's going to happen. Maybe the outlet still works for a half an hour. Maybe the outlet just completely blows up in your face. Maybe you plug into the outlet and there's no electricity going to that outlet. All of those are options for you when you have a traumatic brain injury or a concussion. And what happens is these little membranes, these little frequencies inside the neurons, they shift, where they can go higher, where all of a sudden you walk into a room and you're like, why are these lights so bright? Oh my gosh. And someone else is like, I don't know what you're talking about. Or they could go lower. To the standpoint, you're like, why can't I find my words? Maybe those neurons in a specific area of your brain are not firing to the frequency they used to, and you struggle finding words, or you have trouble initiating tasks, things like that. That's where these things start to become relevant and in play. Question over there.
Get damaged or disconnected and rupture, or are there lesions?
Of course. Yeah, and they're non-specific, right? So in some situations, what we'll see is we'll see there's a term called diffuse axonal injury. And all that means is that when you take the brain and you would twist it and rotate it and put it on top of itself, different neural pathways will become affected, right? Depending on the severity of those neural pathways and the damage will really manifest as how severe your symptoms are. So yeah, the neurons get damaged, which inherently damages the pathways. And now the connections, the conversations between those different systems are inherently affected, right? The analogy that I give patients is we all have that one family member that like always knows the tea. They always know like what's going on with everybody, right? Take that family member out of the picture. Well, what happens? You lose their input, who's talking to everybody else, right? Now, you may still get a little bit here and there from other family members, but that one family member was like the big hub, right? That stuff can happen with concussions and brain injuries, where cell pools that are really important for like processing information can either get taken out or the neurons that communicate with it are no longer helpful. Does that analogy make sense? Okay, so there's a damage and we just don't know where the damage will be, right? And that's why it changes for everybody. What I also think is really interesting too is, in fact, I don't know how you guys process this either, but normally what would happen if I put everybody in here like in an MRI and I was like, I want you to move your right arm, I would see areas of your brain light up like a Christmas tree, okay? So traditionally speaking, I'd see your left frontal lobe and then I'd see your right cerebellum back here. They would light up. You're saying you have activity. And the way MRIs work is that they measure blood flow changes, or functional MRIs measure blood flow changes. So if I do this, I would see more neural activity here. I'd see more blood flow increase there as well. That's a really healthy brain. You want those to correlate tightly together. What happens after brain injuries is you can have a lot of activity going on, but you can actually see a suppression of blood flow to that area. Now that becomes a problem because what does blood flow bring? Oxygen, nutrients. It clears out the garbage, the bad things that you don't need anymore. And so you see this loss of coupling of that neural function and blood flow after concussions and brain injuries. And once again, it's non-specific, right? So we don't always know where this is going to happen or what's going to happen, but that can happen to people. And so with regards to an injury, you can try and rehab and do things neurologically, but sometimes if there's not enough blood flow there, that becomes a problem. Right? So that's why now they're telling people, okay, after an injury, we want you to rest, we want you to heal, but after about a week, maybe about a week and a half, we want you to actually start doing some really low-grade physical exercise or cardio. Not too high, not starting to train for a marathon, but just enough to get your heart rate going and moving as long as you're not symptomatic. because that rehab will actually start coupling the blood flow and the neurological activity together. And we know the prognosis, or the ability for you to improve your functionality, actually improves based off of that. So after a brain injury, we know that pain processing changes as well. Okay, so not only does pain processing change in areas that were directly damaged, but even in areas that were not touched at all are also becoming damaged. So we know that these thresholds of pain can actually turn hypersensitive. So you had a car crash, and all of a sudden you're like, why are my shoulders so painful? I didn't hit my head, I didn't have any injuries, this was just a little fender bender. Well, the sensitization, or the brain, the computer, with the water being poured on it for the concussion, now your processing is a bit skewed. So you kind of default to having more pain, and all of a sudden you're like, this wasn't an issue for me before. Now you're days, weeks, or months afterwards, and you're like, why is this still here? This is actually getting a little bit worse. Those pain cycles are actually firing and wiring and propagating more pain to be experienced, okay? Now, this is quite interesting to me, okay? So with regards to what's actually going on with a brain injury or concussion, most people would associate like a thinking problem or like a speech problem to like a specific area of the brain, your frontal lobe. That's the CEO part of the brain. And maybe I'll just give you an analogy before I go into this. Your brain, I'm just going to go back to all of these really quickly. Your brain is kind of built like a house, all right? So the first thing that we would do if we built a house together is we would build a really stable foundation. And in that foundation, you always have a utility room. In that utility room are things that you never want to look at or think about, but you need. That's plumbing, that's heating, that's sewage, that's HVAC, electricity, all the things that give your house vitality, right? Your brain does the same thing. In these lower areas of the brain right here, these are areas that process things like blood pressure, heart rate, digestion, really basic, simple visual reflexes that we all take for granted until we lose them. And then what happens is we start stacking these stories on top of themselves, where we all kind of live in the third story, the VIP suite, the main room, right? This is our frontal lobe. This is the CEO part of the brain, where we all have thoughts and beliefs and rationality, right? Well, what can happen is you can have an injury to the brain, or you can have an injury to the lower part of the brain, and all of a sudden, it's kind of like your basement flooding or you having a fire downstairs. Would you just hang out upstairs in your master bedroom and just wait for somebody to put that out? No. You'd immediately allocate resources to putting that fire out. And the brain does the same thing. So a lot of the patients that I see who are dealing with brain fog, fatigue, headaches, even dizziness and disconnect, it's not that they have a problem with their frontal lobes, although they can. It's often that these lower areas of the brain are not doing their job anymore, and all of their bandwidth is just being allocated to those lower centers, trying to keep the foundation afloat so that the rest of the house can stay up. Does that analogy make sense? Okay? So we often don't fully know what is going to happen with that, and this is where a lot of the processing problems come into play. The inputs and outputs are a really big deal. So for me, when I'm doing a test with a patient, I'm looking at reflexes, right? As simple as a biceps reflex can be, that's important for me because the input should match the output and vice versa. The analogy that I give my patients is if we decided to book a trip from here to Cancun, right? The first thing we would put into our kayak or to our sky scanner is where do we start and then where are we going, right? That's how you find flights. The knowledge of where you are is really important for us. And this is something that we take for granted until we lose it, is our brains are always asking the question, where am I in space? Where is Erik? Where is my arm? I need to know where my arm is in order for me to be able to grab the podium and know where everything else is at. You have to know where you start in order to know where you're going. And with a concussion, we know that these systems and these circuits get affected. So there are specific groups and specific areas of the brain that become affected. And the analogy that I give, I'm just going to kind of push through. I think one of my slides got missed here. I'm going to push through this, and I want to come to this because this is probably one of the most important analogies that I give the patients in the office is that there are different systems that we rely on that we don't always think about, okay? The analogy that I give patients is this is like the three friends that you have that go to the same party, and you would expect those three friends to tell you the same story about that party, right? Where it was, who was there. I always want to know what kind of food there is, right? But you want them to tell you the same story about that party. And that's important. Your brain is always processing information. Now, these three friends for you, for us as humans, is your visual, your inner ear, and your sensory systems. I'm going to highlight those right here. So your inner ear, also known as your vestibular system, aka your balance systems, all right? This is the system that becomes active on like an elevator or an escalator Even if your eyes are closed and you're moving, you can tell you're changing your relationship with gravity in some way, shape, or form. Same thing of like driving in a car and having your eyes closed. You can feel that you're translating and moving. And that's the inner ear system. Okay, so that's friend number one. That's super important for us. Friend number two is your eyes. Now, I'm not talking about the hardware, which your optometrist can fix, right? So if you have corrective lenses or prisms, I can't touch your eyeball, and I never will, and that's not my job. What's important, though, is the software. It's the can you fix on a target? Can you judge depth or distance? Can you track a target? Can your eyes kick between targets and hit them correctly and efficiently? That's the part that's interesting, and that's what we're looking at with concussions and brain injuries, and that's what we're treating with them too. So you can use the eyes as a test for diagnostics, and I'm going to show you videos, but you can use the eyes as therapy to change areas of the brain as well. The third system is your neck, okay, your cervical spine. Your neck is always giving you feedback. There's a lot of real estate that comes and is represented in your brain from the neck. And that's why most people who have neck issues either struggle with getting care, or when they do get care, things shift pretty quickly. Once you get out of neck pain or your neck is able to be rehabbed and treated, a lot of these other things start playing together nicely. But those three friends have to go to the same party, and they have to tell you the same story about that party, okay? So why this is important is that there are a lot of things that we know about now as far as brain injuries and concussions that are relevant for this. So I mentioned visual integration and visual processing. Once again, this is not the hardware, this is the software. Now, one of the reasons why we look at eyes and why I'm looking at people's eyes all day, every day, is your eyes are a massive window into the brain, and they can tell me a lot. A lot of the new research now coming out is showing that visual rehab, visual training, visual processing, things that Guy and Fran do with neurofeedback with the eyes, all of this is treating the brain in some way, shape, or form. And that's why we can use the eyes as a diagnostic to diagnose. We can also use the eyes as a way to treat as well too. So in my office, the tool that we like to use is video oculography or video nystagmography. Big term, you don't need to know it. You essentially need to realize that we're using goggles and we're having people do different visual tasks, okay? Now I've brought a bunch of videos that can show you what this looks like, what normals and what abnormals look like. And that's probably most of what we'll be able to get to today, to be fair, okay? But I think this is relevant because a lot of the patients that come into our office don't come in saying, hey, I have visual issues that you need to correct. Most of them come in saying, I feel dizzy, I have headaches, I feel off, I have brain fog. Why am I so tired after looking at my phone for 10 minutes? Those are the things most patients come and tell me. I don't know about you or Fran, but no patient has come in telling me exactly what they need me to do to treat them, right? So I'd love that, but that's not going to happen anytime soon. I wanted to show everybody on here why these tests are relevant and what normal and abnormal looks like, because I think it's interesting. And what's nice about this is that it's objective. I can quantify it, and I can run these pre and post, much like what Fran and Guy do for their neurofeedback and EEGs, because I love data. Now, I want the patients to feel better. That to me is the ultimate panacea. But I love seeing objective changes because that means we're changing the neural circuits that are involved with this. So I'm just going to play this video here. So what you're watching, what you're seeing is, you're seeing a patient with their eyes open and they're actually in the dark. Now what's going on is nothing should be happening. They'll get a little light right here, and I want them to look at the light, and I should see their pupils get small. Do you see that? So I'll play it again one more time. So this test is a test to see what the eyes are doing and what the brain is doing without any environmental cues or visual cues. Right? So once again, this is like a patient whose eyes are covered, their eyes are open, and they can't look at anything, they just see complete darkness. Okay, so they're in the dark, nothing's happening, nothing should be happening. All of a sudden, they get a light to look at the yellow mark. Watch the pupils should get small, okay? And they fixate on that target, okay? That's a healthy brain. We like that. That's a normal reflex, that's a normal response, all right? What happens with a concussion is we can see patterns like this. Okay, watch the eyes drift. They're going to drift up and to the left. They're going to snap down into the right. Right here, here's a big one. There's one. There's another one. Okay, here's a big eye movement. Okay, here's the stimulus to look at. See how they still have a problem with those eyes drifting and shifting? Okay, that patient has a pattern called nystagmus. All right, why that's important and why that's relevant is that patient came in with a ton of dizziness. That patient was dealing with a lot of dizziness, okay? And the reason I did that test with them is that they told me they were dealing with dizziness. I want to look at that. And this is the pattern that they had was nystagmus. meaning that those two friends, the eyes and the inner ear, were going to the same party and they were telling the brain completely different stories. There was a bit of a mismatch in that conversation, okay? Now, that doesn't mean they always are going to have dizziness, but I see that pattern quite often. Most docs will miss that. Question over here. Both ways. Yeah. I mean, if you have symptoms, I want to run the test because I want to see what makes it better or worse. But just because you're not having symptoms doesn't mean I can't pick up things neurologically. I can still pick things up sometimes with patients who don't have symptoms because your brain doesn't change that quickly if you have something that's been around for that long. But if you're not having symptoms, you're going back and forth, for me, that's probably a good sign, right? So this may not be as severe, maybe it's more subtle, or maybe it's not even relevant. If I pick a nystagmus up on somebody who's completely normal and healthy, that might not be that relevant to their case. So, but that's a good question.
They might still have it, but it only shows up when they have the actual.
Yeah, and that's totally an option too. Yep, so cool. Okay, I'm gonna show you another video, okay? So this is somebody who is looking at a target, all right? So they're just looking at a target. I'm showing you the normals and the healthies first, so you can see the abnormals after, all right? Now this is a super boring test because that's a healthy brain, all right? They're looking at that target, all right? Now, what you're gonna see next is you're gonna see an abnormal, all right? Not on this one, I'm gonna go here. Okay, so take a look at this. Once again, they're still looking at a target, same target, okay? That's hard. Now this patient didn't come in telling me they got visual issues. What'd they tell me? They've got dizziness, they've got brain fog, they've got a lot of fatigue, and they really struggle with busy visual environments. Well, no wonder, right? If they can't keep their eyes parked on a target, good luck going into Costco, where you've got movement and all of these peripheral visual things going on, trying to just answer that question of where am I at in space. That's an overwhelmed brain, okay? And that was a 15-second test. Extrapolate that to minutes, hours, and days. You're going to be fatigued because your brain's working overtime. So those are the subtleties that we can pick out with the VNG. And as much as I would say those patients come in telling me in their history, I know where to go with that. What I would also say with this too is that sometimes we have to dig a little bit deeper on that. So once again, here's another fixation issue. I think this might be the same video, but you get the picture, right? Now, there's different eye movements. There's different things to do with eye movements. I'm going to show you a different test, all right? So this is a tracking test, and this is something you take for granted. What's nice about these videos is you can kind of cheat with interpreting them. Anything along this gold line, that's kind of like the gold standard. So if it matches the line, you're like, hey, this is a healthy brain, right? Now look at how beautiful those eyes track, okay? This is just a target that's slowly moving back and forth. We take this for granted. Now, every day, all day, I'm moving my head when I'm talking to you. You're tracking things in your environment. Your brain spends a lot of time tracking things in your environment because you're always doing something. That's good. But what happens is, when people struggle with tracking and their brains don't do very well, all of a sudden now tracking turns into this, where now they're trying to track things and all of a sudden, boom, big jump, okay? The brain becomes overwhelmed. It can't pick up the cue. The dot is still slowly moving in the periphery, but now the brain is overwhelmed. Now maybe you get a little bit more of a stress response, a pain response, you get fatigue, maybe a headache sets in now. All of a sudden you have this cascade of symptoms with the simplest task of the brain just not being able to visually track those targets, okay? I see that all the time. And 60 to 80% of patients who struggle with brain injuries struggle with visual pursuits. So, you know, if we're not looking at that from a visual perspective, even on bedside testing and doing this and this in the vertical plane, we'll miss that. So I think I have time for probably 2 more videos, right? And then my time is up. I'm picking this up here. So you saw what those looked like. I don't need to do the verticals. But I will show you the other one that's important for us too, okay? There are fast eye movements that we all take for granted until we lose them. And this is where a lot of the research is showing now with concussions. You should be able to hit a target. When a target shows up, boom, fast eye movement, boom, fast eye movement. You should make one eye movement. You should hit it. It should be specific. It should be fast. We do this with reading, right? Going left to right, hitting letters, going to words, which go into paragraphs, which go into sentences, and all of a sudden we should be able to interpret that. But how many patients with concussions tell you, I don't even know what I just read, and I read a full chapter. Now, Fran and Guy will tell you there's other things for processing which are super important for that, but if those patients can't hit targets, they're not going to be able to understand and interpret what they just read. So when you look at what's actually going on with these brains, there's different parts of the brain that are becoming affected. This is what it looks like when people really struggle with those aspects. So watch how many eye movements they're making just to hit one target. There's 1, 2 there on a bunch, 1, 2 there, right? 1, 2, 1, 2, 3, 1, 2, 3, 1, 2, 1, 2, 3. They're making 3 or 4 eye movements just to hit one target. Do you think that patient's going to be tired at the end of the day? Yeah. Do you think they're going to get headaches? Most likely. Do you think they're probably going to have fatigue, maybe some disconnect? Maybe they're dizzy because they can't even keep their eyes on a target to begin with? Yeah. Okay. So the relevance for all of this is that there are so many things that we didn't know about the brain that we know now about the brain. Okay. And one of the reasons why we clinically use this type of testing is, one, there's a high chance patients have never looked at their eyes before. Before seeing this, had anybody ever looked at their eyes before outside of an eye exam? Probably not. Right? So what's nice about this testing for us is it's objective. I can't make it up. I can't change it. It's quantifiable. So I have numbers and data and feedback, but it's also a timestamp about where your brain was at on that specific day. And what's nice is now as a patient, you can look at that and say, that matches up to when I felt dizzy or nauseous or when I had a headache or when I felt fatigued. We can use it as a report of findings. It's a way to keep us honest as doctors. And I want to see progress with that. Right? Okay. So there are so many other things that can happen with concussions and brain injuries. And Guy and Fran are experts on all of this as well too. So by all means, ask them all the questions. But more importantly as well, in the rest of the slides and the rest of the notes, we go through inflammation, we go through gut issues, we go through metabolic problems, we go through some treatments, things along those lines. So there's a ton of information in there for you that I wanted to just give you and get access to. So take the time after tonight, dig through some of it, ask us questions. We're here for feedback on that, but the rest of the notes are merely there for education and for you to dig deeper and hopefully find some answers. So I think I'm out of time. If not, I'm a little over, but I wanted to thank everyone here tonight for allowing me to come up and spend some time talking to you, and especially to Guy and Fran in the Bhakti Brain Health Clinic. They're phenomenal. If you haven't worked with them, we've worked with patients in the past. Like they're brilliant. And so there's a reason why I'm here just hanging with them. So I'm open for any questions if we have time for that. Otherwise, thank you guys for having me, and I hope you were able to take something away tonight.
Okay. All right. Well, thank you, Dr. Reis. That was always fantastic. So much to learn. So much information. We need to turn this into again, I'm going to say, I find myself saying this after each functional forum. We need to do a symposium and just have an all day so that we can get more of this information said out loud. So just a little bit about who we study with, our mentors, says a little bit about who we are as a clinic and the type of practice that we have. Always get this question, is there research? Yes. So here we're now almost up to 4 million studies. So that's enough to keep most people busy if you wanted to leaf through those 4 million and then come back to me with questions. Here we break it down into some categories so you can kind of see by condition what kind of studies are there. And in the modalities. So you can see that number drops down, but it's still significant. I mean, I was at a presentation and one of the presenters said, and there's no research. And yeah, that's an opinion. And then I was the next presentation and I got up and I presented. And of course I showed, yeah, there's thousands and thousands of papers, but just that idea still lingers so heavily that there isn't just decades of high quality research. And then here, some specific around concussion. So good evidence-based, everything we're going to talk about tonight is evidence-based. Dr. Reis did a great job covering a lot of the basis, the metabolic side of it. So I'm going to have some stuff about that. So I'll just kind of whiz through and hit the highlights that are relevant to what I want to say. I'm going to show a video here that is just going to kind of be a more dramatic way to share what you shared about what happens in concussion and kind of helping us get over the old idea of the coup contra coup, like your brain hits the front of your skull and the back of your skull, and then you like have a bruise on the outside of your brain, and that's the brain injury, right? Not that you can't get damage on the outer layer of the brain from impact to the skull, sure, but rarely is that the excitement is. And so we're going to take a look.
To give you a sense of what might be happening in concussion, I want to show you the video here that you see when you type in to Google, what is a concussion? The CDC website comes up, and this video essentially tells the whole story. What you see is the head moves forward, the brain lags behind, then the brain catches up and smashes into the skull. It rebounds off the skull and then proceeds to run into the other side of the skull. And what you'll notice is highlighted in this video from the CDC, which I'll note was funded by the NFL, is that the outer surfaces of the brain where it was to have smashed into the skull looks like it's been damaged or injured. So it's on the outer surface of the brain. And what I'd like to do with this video is to tell you that there are some aspects that are probably right, indicative of what the scientists think happens in concussion, but there's probably more that's wrong with this video. So one thing I do agree with, and I think most experts, whole room in the cranial vault, only a few millimeters, and it's filled entirely with cerebral spinal fluid, which acts as a protective layer. And so the brain as a whole probably moves very little inside the skull. The other problem with this video is that either your brain is one of the softest substances in your body, and you can think of it kind of like Jell-O. So as your head is moving back and forth, your brain is twisting and turning and contorting, and the tissue is getting stretched. And so most experts, I think, would agree that concussion is not likely to be something that's happening on this outer surface of the brain, but rather it's something that's much deeper towards the center of the brain. Now, the way that we're approaching this problem to try to understand the mechanism of concussion and to figure out if we can prevent it is we are using a device like this. It's a mouth guard. It has sensors in it that are essentially the same that are in your cell phone, accelerometers, gyroscopes, and when someone is struck in the head, it can tell you how their head moved at 1,000 samples per second. So this is our laboratory. And I want to show you the first concussion that we measured with this device. One of the things that I should point out is the device has this gyroscope in it, and that allows you to measure the rotation of the head. Most experts think that that's the critical factor that might start to tell us what is happening in concussion. So please watch this video.
Cougars bring extra people late, but Luck has time. Lucy is crushed. I hope that he's all right.
As at the top of your screen, you'll see him come on just this little post drop, get separation, safety. Here it comes at you in real speed. You'll hear this.
A hit delivered by Case.
Sorry, 3 times is probably a little excessive there, but you get the idea. So when you look at just the film here, pretty much the only thing you can see is he got hit really hard and he was hurt. But when we extract the data out of the mouth guard that he was wearing, we can see much more detail, much richer information. Now, this device is only limited in such that it can measure the skull motion, but what we really want to know is what's happening inside of the brain. So we collaborate with Svein Kleiven's group in Sweden. They've developed a finite element model of the brain. And so this is a simulation using the data from our mouth guard from the injury I just showed you. And what you see is the brain. This is a cross section right in the front of the brain twisting and contorting, as I mentioned. So you can see this doesn't look a lot like the CDC video. Now, the colors that you're looking at are how much the brain tissue is being stretched. And so the red is 50%. That means the brain has been stretched to 50% its original length, the tissue in that particular area. And the main thing I want to draw your attention to is this red spot. So the red spot is very close to the center of the brain. And relatively speaking, you don't see a lot of colors like that on the exterior surface as the CDC video showed.
Yeah, so just trying to illustrate the point with a little bit of physics to show that, so that's the corpus callosum in the middle. So in football, this condition, CTE, this is what they're connecting. If you watch that whole video, he'll go through more of the study that they're trying to show why does CTE happen disproportionately in football, and it's because of that the area of the brain that actually takes the most stress is the center, the corpus callosum. And as those fibers get continually injured, that leads to the disease CTE. So some of the things we want to kind of dispel are these ideas about, like some of the ideas that, again, Dr. Reis said, that you have to hit your head to get a concussion. You don't. We just need forces moving through the Jell-O. And there's a good way to think about it, right? Is your brain is more like Jell-O. So you just need force waves moving through that Jell-O to distort it. And that can be enough to cause an injury. A lot of that depends on your underlying health. So we heard about the MRI, not a good option unless you have anatomical damage. And then great, MRI is exactly the right thing. So I think it's perfectly fine in cases where it's reasonable to suspect that there was anatomical damage to have an MRI. Great thing to do. It is kind of the standard of care for neuroimaging. Most of the time, people we see, so people who do not have grave brain injuries, where the brain is physically damaged, what we see is their MRI is perfectly clear, and what they have is functional damage. So what is that functional damage? Again, a lot of this is a repeat of what we've already heard. So we've got the stretching and distorting, so you can have the actual shearing of synapses. Neurons themselves may be more like sprained, but these tiny little connections, the synapses, those can get sheared, and then we can lose some of those. So we've got layers of damage, but then there's also the chemical flooding that happens. So that can be inflammatory from just a natural response from the body, healing response. It could be a little bit of blood. If there's a bit of a bleed, that can cause inflammation, so that's not the good kind. We have a increase in glucose initially. That can cause a toxic effect. We can have a rise in calcium. Number of things that can change chemically immediately afterwards, and then continuing on for days and weeks. So we've got a physical stressors, we have chemical stressors. Where do these kind of then go into affecting things like memory? But one of the things that I think is a mistake that is too often made is we think about the brain and we think about cognition. And so cognition is, memory, long-term memory, short-term memory, word finding, my academic skills, things of that nature. So what we think of our brain as doing is thinking. And sure enough, that can be affected. But what we spend less time thinking about is that the brain spends the majority of its time running the body. And so think more about our thermal regulation and our hormone regulation and our blood sugar management and our digestion, all of the things that the brain is spending time managing for us. So a concussion can have its effect primarily from here down. And that may be where a person's symptoms show up. And we've certainly seen many cases where that's the case. Fran is going to talk about more about that today in something along the line of a dysautonomia, right? So issue with the autonomic nervous system versus the central nervous system coming from concussion, very common. So more of our autonomic nervous system leading into cardiac issues, thermal regulation, and then of course we have to think about sleep. So in here we have vestibular issues as well. So that's certainly the wheelhouse that Dr. Reis is in. He's our go-to for those specifically. All kinds of systems can be affected in small ways and in large ways. And then because the brain is just a continually running process, if you take 2 or 3 or 4 of those processes and you just knock them off a little bit, that little bit of dysregulation in your hormone system and in your sleep cycle and in your energy production system, that's going to start to have an effect on the brain. So a person may develop cognitive symptoms because of the downstream symptoms that came on from the concussion. So you just get this loop that keeps feeding on itself. So personality issues, if you've known anybody who's had a concussion, it's not unusual for them to have a bit of a personality change. And so these are some of the ways that can show up. So in a way, we could think about like how the mind is affected by concussion, also important to take in. And in that the mind has a downward causation effect on the brain. If the mind is dysregulated, how it is regulating the brain is going to change as well. So emotional changes. So we're going to look at some of all of this today and some of the neuroimaging and how do we see the signs of these in QEEG. So here again, just a graphic example of what happens in those small connections. And we might even go all the way down to something on the level of a microtubule, which is a tiny, 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 tiny little structure that can get damaged. And if we have damage at that fundamental level, then that just has an upward causative effect through multiple systems. So again, this idea that multiple systems, these tiny little systems that we count on, can become dysregulated, whether it is a synapse or an ion channel or the vascular associated with the neurons, any number of systems that can be impacted. So what we're going to take a look at here is some EEG. So I'm going to show you first, I'll say a normal EEG. So I honestly don't know if there is anything, if there's a brain out there that would produce a normal, like a statistically normal EEG. Probably not. But as I always like to say, we have a certain subset of the population that comes to see us, and it's people who have self-selected to say, I'm having an issue with my brain, will you take a peek? So we don't necessarily see the person who's like, I'm doing great. We tend to see the people say, I'm not doing so well, right? So we have a little bit of excuse. Within our EEG that we see, what I'm about to show you is a fairly normal EEG. So, yep, there it goes. So what you should see is you can see a little dotted line in here, and the EEG should kind of hug that line, this little grid line. And you shouldn't see, like, you can see a little bit here in these frontals up here for this person, some eye movement. But for the most part, the EEG is pretty symmetrical. When you get these big bursts, they're nested within each other. So that means they have good synchronization. So are there some issues in this brain? Yep. There are, but in the scheme of things, this is pretty good looking EEG. So we'll take a look at our next one here. And I think it won't take long for you to realize, like, hey, that doesn't look so good. And this is actually somebody that I saw when I was first starting, and I was thankful to him that he made it so easy for me by having a very dysregulated brain. He had suffered a traumatic brain injury, but then, so also I just want to know a few things. So again, up here in the frontals, we see some of these big waves that are moving. Some of this is how the eye movements that Dr. Reis showed you shows up in EEG, because the eyes have a positive charge on the front and a negative charge on the back. So when those charges move, our equipment picks up the variation in charge. So we can sort of see, but with nowhere near the specificity. But when I see EEG like that, with eye movement dysregulation like that, I'm thinking this is a referral to Dr. Reis to specifically look at what's happening in the ocular system. And might this person do better training with him before us? Because those eye movements in our work are going to cause a problem. They won't be able to properly train the rest of their brain if their eyes are throwing off all of those artifacts. So there's a place where the synergy between the two comes in, sort out from our side, kind of the bigger problem. And then when that's settled, come to us and we can do some of the finer work. So this young man, a traumatic brain injury, that then went on to, I would summarize it as kind of a dysautonomia. So his autonomic nervous system just progressively got more and more dysregulated. Eventually, and sadly, what tends to happen is he collected diagnoses. So he had Lyme, and then Lyme with co-infection, and then mold, and all of these conditions that are really, really, really hard to disprove. And he had just years, decades of treatment. And his last thing was coming to see us for neurofeedback. And I'm happy to say we were able to get him back to living a normal life. And probably 20 years of not leaving the house came to an end, and he's out traveling the world. And really, it's a beautiful story. But it was just seeing how a brain injury that kind of got passed off as like, it's not that bad, you'll be fine, actually turned into a complete disabling condition over the years. So this is just what we call a paroxysm, so disorganized EEG. If you look here, nice and neatly organized, even here, nicely, it's pretty easy to look at that and just kind of go, oof, right? Even if you don't know what it is, you're just like, it's not good. And it isn't. This is a brain that episodically, for just a few seconds, just loses the plot. And if this progresses, this becomes epilepsy. But here it's just a paroxysm. But it's a sign that the brain is losing its internal pacing. So here's some of the imaging that we get, so reports that we get. So this is a traumatic brain injury index. So we run this on everybody. They may or may not report a brain injury, but if this comes up as a positive, we're going to go back and have a deeper conversation with them to see if we can find out was there. And I would say it's about 50-50, because a lot of people, let's say, our age, look around the room, our age, I'll leave out the edges back there. There were concussions and it was like, you're fine, get back in the game, away you go, or whatever it is, just dust yourself off and keep going. So those folks, they have no sense, because nobody ever said to them, I think you have a concussion. So it didn't register. But we have a really nice sensitive test to give us some idea. Here, this is very specific, so independent component analysis. Just simply say that this red line here, this isn't good. This should have a very specific shape, and it's not that shape. So for us, we look at that immediately and we say, this brain is running too slow and too fast at the same time. And so it's out of sync with itself. That's bad. When we look here at where that is, there's these two primary areas in the brain, the anterior and posterior cingulate, which is our primary regulatory circuit. So regulating our body. regulating our emotions, and then in the frontal lobe, kind of regulating what we say is how we think about how we feel. So dysregulation is in this core regulatory circuit. And coming from a concussion, we know that this person is going to have a spectrum of symptoms coming from this. They're going to have some of the autonomic kind, they're going to have some of the emotional regulation or psychological kind, and they're going to have some of the cognitive. And so for us, working on regulating that core circuit allows us to hit all of those levels with one form of training. So mitochondria, right? So mitochondria can affect us from an energy standpoint, but also mitochondria do a lot of information processing. So they're like the mini brain before the brain. And so they're processing information as well. So if they're injured, we have two processing problems. And so they feed into network activity. So here's how we look at networks in the brain. And so we get an overall, so this is getting attention getting, even within our population. If somebody's in the red, we're like, oof. If they're over here in the orange, it's going to, the functional kind of quantification of all of the things you've heard tonight about synapses that have been broken, neurons that have been sprained, too much chemical in the wrong place, all of those things that cause dysfunction in our system will map out like this. So one of the things that can happen when you have a brain injury is your brain can kind of go into survival mode and it will just down-regulate its activity. So we'll see this in this pattern. So these cool colors say 2 or lower based on a comparison to an age and gender matched normative database. So a database of peak performing brains. So this person is 3 standard deviations, 2 standard deviations, too little activity. So this is an example of a brain that has gone into shutdown mode. Right, so we call it a low voltage EEG. Over here, on the other hand, this person has moved in a little bit more of a classic concussion where their brain has slowed down. So they're overproducing theta, so a very slow brain wave, also overproducing delta. So this is probably the most common thing that we hear about. And then you can see up here, the brain waves more associated with cognition are, again, decreased. So 2 very different ways that a concussion can show up in a brain. Yes?
If a patient came in with like that theta, would you treat him or her with a beta wave? Or can you do that with the neurofeedback? On the opposite of that?
So you might try and just encourage this brain by giving it what it doesn't have and see if we can pull it up. So we might just do that. We might also give it an inhibition, so to tell it to kind of stop producing theta, so it gets a negative reward for doing the thing we don't want and a positive reward for the thing we do want. So a couple of different strategies to work with it, kind of direct, indirect, and that's part of the art and science of this, is finding out what does that brain want as a path back to the regulated. So just a little bit so what do we do when all of these things happen? So we've just talked about, EEG as having biomarkers for patterns of dysregulation in the brain that can be related to function, over against looking at a MRI that will tell you none of that. Like 100% of none of that will come from an MRI. You might get a little information about blood flow, but that's about it. Again, we compare to a normative database, so that gives us some idea of normal, right? But we also get specifics about that brain. How is that brain doing what it's doing? But also, how is that brain doing it compared to a healthy comparison? And that gives us some insight. We now have kind of abnormal databases, which we didn't have. So like that traumatic brain injury database that tells us about pathology. We have databases now that can match us for anxiety, depression, ADHD. So we can get some more information on the pathology side as well. So from our typical form of neurofeedback is the 19-channel Loretta neurofeedback, where we're able to train hundreds of metrics at one time and to try to bring the brain back into synchronization with itself a little bit at a time from a number of different nudges, kind of nudging it back in the direction we want it to go. Photobiomodulation, one of my favorites. It has so many positives to it relative to what can be happening in traumatic brain injury. So it's great for reducing neural inflammation. So it's really hard to get an anti-inflammatory into the brain because of the blood-brain barrier. So putting light in means we can bypass the blood-brain barrier and have a strong anti-inflammatory that is also a nutrient. increased cerebral blood flow. We talked about the energy shutdown that can happen because of kind of the shock or trauma to the brain. Yep.
I just got a little confused. Were you saying we're putting something into the brain to see it better?
Nope. To treat it. So near infrared light to treat inflammation. You got it. So increasing mitochondrial activity, again, cell-to-cell signaling, energy production, transcranial electric stimulation, helping to normalize membrane potentials. We can use entrainment to help, is what Dr. Hanna just asked the question about. Might we put in, say, a beta wave using transcranial electrical to encourage that brain to produce more beta waves? Absolutely. So there's a number of different ways we can use the transcranial stimulation to kind of nurture that brain back physiologically and functionally. And then it's Fran's turn.
Okay, so we have 4 minutes. And what I was thinking about as I was sitting there thinking, how am I going to say anything in 4 minutes? I remembered that I'm the youngest in my family. I had 4 older brothers. I'm very used to doing the last leg of the race and grabbing the baton and getting over the line in a very quick time frame. So that's what I'm going to do. I'm going to kind of sprint, which means I'm going to just share a little bit of information, but not a ton. So in most of what has been talked about already is relevant to what I'm going to say here anyway. Guy had mentioned a little earlier about the autonomic nervous system, and that's the piece that I want to talk about in regards to concussion. So one of the things that oftentimes happens when somebody gets a concussion is, you do the kind of standard treatment and care and kind of get to a point where most of the sort of quote unquote typical concussion symptoms are over, right? Or at least you seem to have progressed through and gotten much better with those. But people oftentimes still feel a sense of like not feeling quite right. And oftentimes what happens is that is actually the result of an autonomic nervous system that is dysregulated, right? So oftentimes it just takes longer. So there's like this lag time with the autonomic nervous system. So other symptoms can be gone and the autonomic nervous system is still dysregulated. And so we think about that. That's the fight, flight, freeze, or shutdown system, right? And when that gets dysregulated from concussion, oftentimes what we see is people that continue to report symptoms like sleep difficulties, brain fog, executive function sorts of things. And so that maybe the dizziness and some of that the vestibular stuff has cleared up, but they have these continuing symptoms of dysautonomia, which Guy had mentioned earlier. One of the things we do in the clinic when we do a QEEG is we always monitor their autonomic nervous system as we do that assessment, as a way for us to kind of get a read on that. That is one of the really useful ways to be able to figure out whether or not the autonomic nervous system is working well and whether or not it's kind of like a recovery biomarker for the autonomic nervous system. And so that's kind of a standard routine assessment that we do in the clinic. When the autonomic nervous system is dysregulated, it really is like it leads to lower recovery rates overall. And it can really, and when I talk about lower and slower recovery rates, it can be years, right? Over a long period of time. And it's the kind of thing that people just sort of get used to having happen. And so they don't pay as much attention to it, but they know that they just continue to feel off. It can also, when the autonomic nervous system is dysregulated, HRV, heart rate variability is lowered, that oftentimes leads to like post-concussive anxiety, sometimes almost a PTSD sort of reaction that somebody can have, again, over an expansive period of time. I'm going to briefly touch on a couple of interventions. I'm not going to say much about what's on the slides because Dr. Reis has talked a lot about this. Guy talked a lot about it as well. And so I'll just talk about sort of the intervention piece that we might do from a brain health neurotherapy perspective. So Guy mentioned a transcranial alternating neurostimulation, right? So we do alternating current stimulation. That can be really good for getting the brain connected again. So oftentimes with concussion, one of the things that happens, I loved the visual that Dr. Reis puts up about the connections, the brain with all of the nerve connections, right? Just showing that. Because when those get severed, they create all kinds of problems in terms of brain communication, right? Systems communication, that sort of thing. And that's where neurostimulation can be very helpful. So maybe somebody has, like Guy showed the one picture of the concussed brain that had a deficit in alpha, right? So maybe we're going to do a stimulation at an alpha frequency to get that brain to start kind of syncing with that stimulation frequency and start producing more of a regular pattern of alpha. And so oftentimes that's a real benefit that we can do with somebody who has concussion. Guy talked about photobiomodulation and the idea of reducing inflammation. So again, the connection here with the autonomic nervous system, that level of inflammation can really throw off the functioning in the brain. And so photobiomodulation can be really good at reducing inflammation, which can then allow the brain to kind of engage in some of the things that it might not normally be able to do when it is dysregulated. And so the kinds of, like, it can start to, that sympathetic nervous system that's kind of gotten stuck on can start to get a little bit more regulated. We start to see more of a balance between the sympathetic and the parasympathetic, and pretty soon the symptoms that were things like brain fog, cognitive difficulties like executive function, sleep issues can start to diminish for the client. And then we use audiovisual entrainment an awful lot when it comes to looking at autonomic nervous system regulation. This audiovisual entrainment helps the brain to start producing particular frequencies. So there's a frequency following effect that happens. You have pulsating light stimulus and pulsating auditory stimuli that pulse at particular rhythms based on what it is that you're trying to do. And so you put on an audio-visual entrainment protocol that maybe is in the maybe low beta range or maybe an alpha range as a way of starting to kind of calm the brain a bit. Sometimes a gamma can be helpful in that way as well. And as the brain starts to kind of follow the frequency that is being produced by the visual and auditory stimulus, it starts to kind of create more of sort of like a state of that particular. So if we're doing alpha, it's a calming state, a calm, or maybe a calm focused state. And that starts over time. Well, it can, like in the immediate, it can really help with regulating the autonomic nervous system. But if this is used on a daily basis, it can really start to get the nervous system, the autonomic nervous system, to kind of just regulate in a way that kind of has a much more balanced baseline to it. This is a video of neurofeedback, I believe. Yes, I'm going to show you briefly. Many of you in here know what this looks like, but for anybody who's watching online, just a little bit of kind of, this is what neurofeedback looks like. This is 19-channel neurofeedback happening. What you're seeing here is an EEG cap that is feeding information into that computer database that Guy was talking about that's normed for this young man's age and his sex. And it is reading what is happening in his brain while he is watching his brain play this video game. Whenever his brain starts to behave like the database of kind of quote unquote neurotypical brains or non-dysregulated brains, that computer is going to tell the video game to have him be successful. And so you're going to see the plane might fly through the target. There's a visual stimulus that happens because it flips over. There's an auditory stimulus. There's like a swishing sound. Those stimuli are rewarding for the brain. And the brain, when it gets rewarded, wants more reward. And so we just are operantly conditioning the brain, right? And as it is being conditioned, it's learning how to behave, which means, run the neural circuitry that is more optimally functional. And it's going to continue to learn how to do that. And over a course of repetition, we're allowing the neuroplasticity then to just kind of let it run its course. You saw he had some sensors on his hand. He's got a respiratory belt on him. We are monitoring his autonomic nervous system while he is doing neurofeedback. We might even, between rounds of neurofeedback, do a little bit of autonomic training with him, giving him a breath pacer, having him follow that. Sometimes we actually do both of those at the same time. We'll do an auditory pacer, and they're getting neurofeedback, helping their central nervous system and regulating autonomics at the same time. So I am going to move through here just because we are really short on time. And so I would be remiss as a psychologist if I didn't start throwing some of this stuff back in. I've been feeling bad because oftentimes when we do presentations, all we do is talk about the technology stuff that we do with the brain, which is incredible. But there are all kinds of tools that we can use to help regulate kind of create better vagal toning, regulate the autonomic nervous system. And so this is just a few examples of that. HRV breathing, like I said, we do that with clients on a regular basis, and we set them up and we send them home with they can use a breath pacer and start doing that homework on their own. It can have incredible impact on regulating nervous systems, making sleep better, those kinds of possibilities. The others are all kind of more like behavioral interventions as well. There's an orientation scan, there's the humming and vocal toning, the VU breath, the dive reflexes, which is about cold water, a cold pack kind of on this area of the face. These are all meant to stimulate the vagal nerve so that it can get the parasympathetic system, that's the rest and digest part of our autonomic nervous system, back online. And the beauty of these is that you can do them very quickly anywhere. A VU breath is 5 breaths in and out, and then you're good to go for that round. Humming is one of my all-time favorite vagal nerve things because we can do it absolutely anywhere without looking silly, right? People hum all the time. Anything you're doing to stimulate, so the vagal nerve is running, it runs from the bottom of your skull, it goes all the way down through your chest into your gut, right? And so anything that is vibrating, like stimulating the vagal nerve, so humming vibrates the vocal cords, which are sitting right next to the vagal nerve, which is going to stimulate that vagal nerve, right? But if you hum the right way, which is kind of a lower hum, you're going to feel it in your chest. You might even be able to feel it closer to your belly. That kind of process can be really helpful. So when you're feeling stressed out and when people with concussion are kind of in that kind of post-symptom, but I still feel pretty not me, right? That place, they can engage in some of these more behavioral strategies. And then I'm not going to talk about, you'll get a copy of this PowerPoint, you'll get a copy of Dr. Reis' PowerPoint, and so you can take a look at that. Take a look, we've got a couple of different case studies, I think, in this PowerPoint that really kind of give you some sense of what like treatment with neurotherapy can really do to improve symptoms of concussion. I'm not going to talk about this, but this is an example of looking at autonomics, monitoring autonomic nervous system regulation, and then training it. And then this is contact information for us at the Brain Health Clinic. So if you are ever, if you have questions, you're welcome to contact us to schedule a consult. If you have your brain mapped, we are happy to do a QEEG. We've got a brain spa, which is a way that you can kind of engage in some of our neurotherapy, kind of on more of a short-term basis. Contact information there. I'm going to be quiet. Pass the baton, yay me. Questions that you might have either for us, for Dr. Reis, this would be a good time to ask them.
So any questions before we make it an official wrap?
Is brain fog almost always a result of inflammation, or are there other reasons? What might they be?
Go ahead.
Okay. Inflammation is a great one, but there's so many different ways that the brain can be mildly dysregulated. A person could have GI issues, and then that can cause brain fog. You might have liver issues, so your liver isn't filtering the way it should be, or your kidneys aren't balancing your sodium potassium levels the way they should be, and that could lead to brain fog. So there's an unlimited number of possible ways that a person could have brain fog. And brain fog is a fairly distinct experience for the person having it, but the actual, like trying to pin it down for a given person. So we have people who come in who won't use the term brain fog, but after they describe it enough, we're like, brain fog. But that still doesn't tell us anything about why. So yeah, it is unfortunately one of those kind of catch-all categories that grasps an experience, but tells us nothing about the cause. I mean, not just from that. Yeah, I mean, challenging question, because if we just looked at the brain, which we've learned from experience, if we just looked at the brain and didn't look at the autonomics, we might miss an obvious cause. But keep in mind, we are looking at the electrophysiology, and the actual cause might be in the physiology. So our test might not pick it up. It might need to be a blood test.
If it's a hormone issue.
Could be a hormone issue.
Yeah.
Yep. Any of the hormones could be off. That is creating dysregulation that is then experienced as brain fog. So that's the challenge with that as a symptom when somebody comes in, is like, we know enough to say, well, let's figure it out and start working through, but we may not actually have the answer. So that's where we use our referral network, like Dr. Reis showed today, that we're dysregulation in the vestibular or the ocular motor system. That could be the cause of it. So, yeah.
Even though tonight was largely about like concussion neurofeedback, anybody can get neurofeedback.
Absolutely. Our mantra is our ideal customer is anybody with a brain. And what we do is we help brains do what brains do better. And so you don't have to have a problem to benefit from what we do. It's kind of like going to the gym. You kind of say, like, I go to physical therapy because I have a problem, but I go to the gym because I'm trying to be healthy. So we're both. We're physical therapists, but we're also the athletic trainer at the gym who's just helping somebody get beach muscles or get ready for their vacation or whatever it is. Thank you all for coming. Appreciate it.
Thank you.